Bismillah ar-Rahman ar-Rahim. This is the second lecture about ovarian disease, which is malignant disease of the ovary. Ovarian malignancy is the second more gynecological cancer after endometrial cancer. Poor survival rates. Why? Because of late presentation of disease. Most of them diagnosed in stage 3 or 4. Risk is about 1.4%. 80% of ovarian cancer are epithelial origin or epithelial ovarian cancer. Mean age of presentation is 64 years old. Most common in developed countries. What about the etiology and risk factors? First of all, incessant ovulation theory. What's the ovulation theory? This is mean continuous ovulation. What will cause? It will cause epithelial cell damage. This is the ovulation in the ovary. So, when there is continuous ovulation in the life of the female, there will be damage of the epithelium of the ovary, continuous damage of the epithelium. And when there is damage in the cell epithelium, there will be cell division for healing of the tissue. This cell division is predisposing factor to tumor formation. دائما من يصير عندنا more cell division, more injury of the tissue, there will be abnormal cell division and abnormal development of tissue. So the decreased risk are those with decreased ovulation. Those women who has or had history of decreased ovulation, they already have decreased risk of ovarian tumor. Like during pregnancy, any pregnancy there will be decreased ovulation for 9 months. Those using oral contraceptive pills, those with breastfeeding it will cause decrease in the ovulation or anovulation cycles. While increased risk in those with nullipara, no pregnancy, no breastfeeding, there will be more ovulation and more cell division and more risk for ovarian cancer. Early menarche and late menopause. So the female has a long period of ovulatory cycles. Second risk factor is subfertility treatment, especially when we used for prolonged ovulation induction. Genetic factor. 10 to 15% of epithelial ovarian cancers are familial, hereditary, usually with serous adenocarcinoma, which is one type of epithelial ovarian tumor. What are the genetics factors? We have commonest gene mutation are called BRCA1 and BRCA2 genes. BRCA1 occur in 80%, while BRCA2 in 20%. Most commonly is BRCA1 gene mutation. When there is a mutation, the woman liable for developing breast and ovarian cancer. This is usually autosomal dominant hereditary. Breast cancer risk in positive BRCA genes is about 80%, so it's very high, breast cancer. Also can develop ovarian cancer. Another hereditary genetic is hereditary non-polypoidal colorectal cancer, which is called Lynch syndrome. This is associated with endometrium cancer and 10% risk of ovarian cancer, as well as colorectal cancer. This is also hereditary. Management of women with family history, with positive family history of breast or ovarian tumor. This depends on the woman's age, reproductive plans, and individual risk. Most of these families have history of ovarian, breast, or colon cancer. If just one first degree affected, the risk will be just 5%. If two first degree affected, like her mother or her sister, the risk will be 40%. Hereditary ovarian cancer occurs 10 years before the sporadic one, so it will occur earlier. The most common hereditary cancer is the breast ovarian cancer syndrome, BRCA gene, accounting for 90% of hereditary cancer. So, if suggestive hereditary ovarian tumor يعني خلينا نقول female عندها first degree affected, just only one or two or more first degree affected. كانت تكون أختها أو أمها عندهم risk factor, عندهم ovarian or breast cancer. Then, what we will do? We do BRCA1 and BRCA2 genes study for the family. Screening using transvaginal ultrasound and tumor marker like CA125 has not been shown to improve survival in women with familial predisposition to ovarian cancer. There will be no any rule for ovarian cancer screening. مو مثل البريست كانسر، مو مثل السيرفايكال كانسر. هناك عندنا سكرينينج كل سنة المريضة تسوي ممكن ماموغراف، كل سنة ممكن تسوي باب سمير فور سيرفايكال كانسر. الأوفرين كانسر ما بي سكرينينج رول. Prophylactic bilateral salpingo-oophorectomy has a role in women with positive gene mutation after completing family and after 45 years old, although it doesn't eliminate the risk of primary peritoneal tumor. يعني هاي اللي عندها risk factor hereditary risk factor ممكن أسوي لها البركات جين إذا طلع عندي بوزيتيف ممكن أسوي لها bilateral salpingo-oophorectomy prophylactic. شلون يسوون bilateral mastectomy prophylactic؟ ممكن نسوي oophorectomy bilateral prophylactic. ليش؟ لأنه ممكن يكون عندنا 40% there is risk of ovarian cancer. هاي إيش وقت نسوي إذا كانت complete family old age women. Other risk factors like endometriosis, smoking, intrauterine device, and obesity. What about the staging of ovarian cancer? We have 4 stages. Depends on clinical and pathological assessment. شلون أقسم الستaging؟ هنا أعتمد على الكلينيكال and pathological. Pathological is very important for staging of ovarian cancer. We have 4 stages. Stage 1 about 25%, stage 2 10%, 50% stage 3, and 15% stage 4. So, it's about 65% female presented with stage 3 and more. Why high? Because of insidious nature of sign and symptom of ovarian cancer. دائما تجينا asymptomatic. دائما السيمتوم يصير later on when there is metastasis of the ovarian cancer. What about the metastasis? Either direct separate to the peritoneum, omentum, and other organs, or lymphatic to the pelvic, inguinal, and para-aortic lymph nodes. Stage 1. The growth limited to the ovaries, to one or both ovaries, not outside the ovary. We have 3. Stage 1A, the growth limited to one ovary, no external tumor, intact capsule of the ovary or tumor, and no ascites. هنا الtumor with intact capsule, not rupturing, no tumor outside the capsule of the ovary. And affected one ovary, this is stage 1A. Stage 1B, both ovaries affected. The same criteria, but both ovaries affected. This and this. Those are both lesions with no external tumor, intact capsule of the tumor and ovary, and no ascites. Stage 1C, either stage 1A or B, but tumor on the surface of the ovary, or with the capsule rupture of the tumor, or when we do washing or acidic fluid aspiration, there will be cancer cell positive. This is stage 1C. Stage 2, the growth here limited to the pelvis, outside the ovary, limited to the pelvis, not outside the pelvis. We have also 3 types. Stage 2A, extension or metastasis to the uterus or tubes. هذا نشوف ovarian tumor metastasis to the tubes or uterus. Stage 2B, extension to the other pelvic organ, to the pelvis, other pelvic organ, the metastasis. Stage 1C is stage 2C, sorry, is stage 2A or stage 2B, but with positive washing or ascites fluid for malignant cell. يعني بنسوي washing of the peritoneum أو ناخذ الأسيتيك fluid if there is ascites present. طبعا هذه during operation راح نلقى بيها cancer cell نسميها positive washing or ascites. What is the stage 3 of ovarian cancer? The growth limited to the abdominal peritoneum or retroperitoneal or inguinal lymph nodes. هنا the growth limited to the peritoneal cavity or inguinal lymph nodes. هم عندنا 3 types. Stage 3A, tumor grossly limited to the pelvis with negative nodes, no lymph nodes, but histologically confirmed abdominal peritoneal implant. احنا السابعة شوي رح ناخذها during surgery. ايش رح ناخذ من نسوي surgery for ovarian tumor? We will take biopsy from the lymph nodes, retroperitoneal lymph nodes, pelvic lymph nodes, and biopsy from the peritoneum of the abdominal wall, retroperitoneal or abdominal wall, peritoneum, also biopsy from the capsule of the liver and from the diaphragm. If there is microscopical confirmed metastasis to the peritoneum, this is stage 3A, just by microscope, not by macroscopical, not by vision. Stage 3B, when the abdominal implant, vision by eyes, but 2 centimeters and less in diameter, very small implants in the abdominal wall and the peritoneum. This is called stage 3B. Stage 3C, abdominal implant large, more than 2 centimeters, or positive retroperitoneal lymph nodes or positive inguinal lymph nodes. This is stage 3C. When we open the bilaparotomy, we see the gross pelvic tumor, and there will be gross metastasis of the tumor to the peritoneal wall in the abdomen, and it is large. هاي راح نقيسها if it is 2 centimeters and less or more than 2 centimeters, and the staging accordingly. Stage 4, tumor involving one or both ovaries with distant metastasis, like metastasis to the liver parenchyma or malignant pleural effusion, means metastasis to the lung. This is called distant metastasis, stage 4. Liver parenchyma is stage 4. Capsule or peritone cover the liver. This is stage 3, not stage 4. What are the classification of ovarian tumor? We have 4 classification. If you remember, we like the classification had been taken already in the first lecture. We have epithelial ovarian tumor, which is most common ovarian malignancy. About 80% of ovarian malignancy are epithelial. Germ cell tumor, about 10%. 6-cord stromal tumors, about 10%. Metastatic tumor, very rare. Secondary metastatic tumor. The first 3 are primary ovarian tumor. The last one is secondary ovarian tumor. The first 3 classification according to their origin, whether the origin from epithelial tissue, the origin from the germ cell, or the origin from 6-cord stromal. Epithelial ovarian cancer is very important because it's about 80% of all ovarian malignancy. We have 4 types. You remember this picture from the last lecture. This is the origin of epithelial ovarian cancer or tumor. The origin is the coelomic epithelium that covers the urogenital ridge. The urogenital ridge will develop into tube, uterus, and cervix, into kidney and urinary system. So, we have serous cystadenocarcinoma, which arises from the tube. We have endometrioid cancer arising from the uterus. We have mucinous adenocarcinoma arising from the cervix. And we have clear cell cancer arising from mesonephroid cells. Primary tumor is usually benign. So we have 4 types of epithelial ovarian cancer. First of all, serous carcinoma or serous cystadenocarcinoma. This is the most common epithelial ovarian cancer, which is about 75% of all epithelial ovarian cancer. Most have both cystic and solid elements. Even by ultrasound, we will see cystic and solid element in the ovarian cyst. So the ultrasound say to us, writing to us, it's complex ovarian mass or tumor, often bilateral, lined by cuboidal cells secreting thin serous fluid. By histopath, the tumor characterized by concentric ring of calcification. This is called psammoma bodies. Those are the psammoma bodies. Concentric ring of calcification on the cells. Mucinous cystadenocarcinoma. It is just 10% of epithelial ovarian cancer, usually multilocular. This is multilocular, multiple small cysts, lined by mucus-secreting columnar cell, secreting a mucinous fluid. Usually large-sized tumor. The mean size of it is about 20 centimeters and larger. Pseudomyxoma brittonii. It's a complication of mucinous cyst. This is a rare complication of mucinous cyst after rupture of the cyst, whether intraoperative or even before the operation. Incidental rupture of the mucinous cyst, whether benign or malignant. Pseudomyxoma brittonii usually borderline malignancy or well-differentiated cancer. Seeding growth that continue to secrete mucin. Usually, when there is rupture of mucinous cyst, there is seeding of mucinous cells that will continue to secrete mucinous material. This mucinous material will cause matting of the bowel together and sometimes obstruction of the bowel. This is the omentum, cake-like omentum, and this is the bowel filled with mucinous tumor. Number 3, endometrioid carcinoma. Resemble endometrial cancer, like adenocarcinoma of the uterus. Cystic, unilocular, and contain turbid brown fluid, like chocolate material, the fluid inside it. Usually good prognosis tumor. The last type is a clear cell carcinoma. This is the least common epithelial ovarian tumor and very poor prognosis tumor, fatal tumor, characterized by clear cell similar to renal cancer, often associated with endometriosis and endometrial cancer. We have another type of tumor is borderline epithelial ovarian tumors. اللي حكينا عنه هو epithelial ovarian cancer. هنا عندنا borderline malignancy epithelial ovarian tumor. This is 10% of epithelial ovarian tumor. Cells show. Why called borderline malignancy? Because the cells show malignant changes like nuclear atypia and increasing in its activity. But There is no invasion of stroma or basement membrane of the tissue. So it's called borderline malignancy. There is malignant cell, but no invasion of the basement membrane. So when there is no invasion, it's confirmed to the ovary. No wide separate metastasis. Very good prognosis. Most are serous, and some of them mucinous in type. What is the clinical feature of epithelial ovarian cancer? قلنا الابithelial ovarian cancer is 80% of all ovarian cancer. Most symptoms are non-specific, so 65% of patients present with stage 3 and 4. Unfortunately, the symptoms are unsigned, pelvic and abdominal pain, abdominal swelling and bloating, difficult in eating, irregular vaginal bleeding, fixed mass by abdominal examination. By PV examination, fixed hard irregular adnexial mass. When we see by PV examination fixed hard irregular mass, less than 20% in young women and more than 50% in postmenopausal women are malignant. So high malignancy in old age women. What about the diagnosis of epithelial ovarian cancer? First of all, tumor markers like CA125 elevated in 80% of epithelial ovarian cancer. This is very common tumor marker for epithelial ovarian cancer. Ultrasound. Suspected malignancy are the morphology of the cyst, especially when we see bilateral tumor of the ovary, when see ascites and omental deposition of the mass. CT scan and MRI for metastasis, chest X-ray also for metastasis. Biopsy is the final diagnosis after surgery, to see whether if it's benign or malignant. So the final diagnosis on the biopsy after the surgery. No rule for screening of ovarian tumor outside the clinical trial, as we said previously in the beginning of the lecture. What are the tumor markers? لازم احنا كلنا نعرف التيومر ماركرز وكل وحدة ايش تدل على شنو التيومر مالتها. The most common tumor marker is CA125, which is most common associated with serous cystadenocarcinoma. As we said, serous cancer is the most common epithelial ovarian cancer of the ovary. CA19, most common with the mucinous ovarian cancer. Beta-HCG, can we see it in dysgerminoma and non-gestational choriocarcinoma of the ovary. Alpha-fetoprotein in yolk sac tumor and in teratoma. Inhibin A and B is a tumor marker of granulosa cell tumor because granulosa cells secrete large amount of inhibin. Estradiol is a tumor marker of theca cell tumor because the theca cell secretes estrogen. Management of epithelial ovarian cancer. What's the treatment for epithelial ovarian cancer? First of all, is the surgery. Second, chemotherapy. Sometime plus minus is the radiotherapy. The most important is surgery followed by chemotherapy. We have many types of surgery. The objectives of surgery are for diagnosis. First of all, as we said, the histopath is the last diagnosis of ovarian tumor, whether benign or malignancy, and the type of malignancy. Very important for staging. مثل ما أخذنا بالstaging يعتمد على السيرجري، يعتمد على الهيستوباث pathological. Third and the last aim of our surgery is removal of all visible tumor. لازم أشيل أي شيء أشوفه قبالي related to the tumor, and no any remnant tumor cells behind it, especially more than 1 centimeter. There must be at least less than 1 centimeter remnant behind us. مرات يكون إنه التيومر سايت مالته very dangerous، ما أقدر أتحرش بيه. لازم يكون أقل من 1 سنتيمتر. ليش؟ حتى يكون responsive to the chemotherapy later on after surgery. If it's large, so will be not respond to chemotherapy and the recurrence rate will be very high. The first step of the surgery called the primary surgery. This is the commonest surgery done in the ovarian cancer. What's the primary surgery? The skin incision is usually vertical. Why vertical? To gain access to the upper abdomen. We have two types of incision in the gynecological surgery. Either transverse lower abdominal, this is commonest used for cesarean section, or midline vertical. This is vertical incision. For ovarian cancer, better to do vertical. Why? So we can extend up and see the upper abdomen, the diaphragm and the liver and the omentum, to see them, and if there is any nodules or tumor tissue, we can remove them easily. Second, after we do the incision, then we open the abdominal cavity and we will see the ascites. If the ascites is present, we aspirate the acidic fluid. If there is no ascites, then we will do peritoneal washing with normal saline. And the wash will be taken for cytological examination for any cancer cell or malignant cell. Then we will do total abdominal hysterectomy and bilateral salpingo-oophorectomy. We will remove the uterus and the cervix. This is called total abdominal hysterectomy. We will remove the tubes and ovaries. This is called bilateral salpingo-oophorectomy. This part all removed in the cancer of the ovary. Next step, we will do infracolic omentectomy. We will remove the omentum from the transverse colon. All the omentum removed and sent for pathology. Pelvic and para-aortic lymph nodes are also removed. This is important, especially in early stage, for further surgical staging. لأنه احنا قلنا if there is positive retroperitoneal lymph nodes or para-aortic lymph nodes, there will the stage will be 3C. The liver and diaphragm should be inspected, and if there is any diaphragmatic nodule, should be biopsied and sent for histopathology. This is the primary surgery for any ovarian tumor or malignancy. The second type of surgery called interval debulking surgery. This is performed in advanced ovarian cancer when we see stage 4 ovarian cancer, all the abdomen involved with the tumor and malignancy and metastasis. So the patient must respond to 3 courses of chemotherapy. احنا ايش راح نسويها? We will give the patient 3 courses of chemotherapy, and there must be a response for this chemotherapy. How we can see the patient is response or not? By ultrasound, decreasing the size of metastasis and tumor by tumor marker will be decreased. Then, after surgery, the chemotherapy should be resumed after the operation immediately. رأساً after the operation, the chemotherapy resumed. Women with residual disease following primary surgery, second debulking surgery can be done. يعني نسوي primary surgery اللي شرحناها بالسلايد القبله. After follow-up, there will be residual disease. During the follow-up, by ultrasound, by CT scan, MRI, there will be residual disease, residual masses or tumors in the pelvic, in the abdomen. Second debulking surgery can be done. ليش نسميها debulking هنا؟ لأنه دائما تصير بالadvanced ovarian tumor. ما راح نقدر نشيله كليته، فيسموها debulking. قدر الإمكان نشيل اللي نقدر نشيله، ونعوف أقل شيء، أفضل شيء إنه يكون less than 2 or 1 centimeter behind us. to be responsive to chemotherapy. هاي لذلك نسميها debulking surgery. Third type of surgery called second look surgery. Planned laparotomy after the end of chemotherapy to assess the response and resect any residual disease. But with no survival benefit, so not recommended. هاي بعد ما نسويها، كان قبل يسووها. يعني after laparotomy and the primary surgery and after chemotherapy يرجعون يفتحون بطن المريضة يشوفون if there is any residual disease ويرجعون يشيلوه. شافوا هاي ما منها فائدة، بالعكس الكومبليكيشن تزيد بيها. So not recommended. Number 4 type of surgery called conservative primary surgery. What's the meaning of conservative? Meaning fertility sparing surgery. ما أشيل كل شيء. To serve the fertility of the female. When the tumor is unilateral and encapsulated, like in stage 1A. What are the indications for conservative surgery? إذا عندي stage 1A من ألقى التيومر is just unilateral in one ovary. The second ovary is healthy and the capsule is intact. The tumor capsule not ruptured. We can do conservative surgery, especially in young women and nullipara, not complete her family. What's the conservative primary surgery? It includes unilateral salpingo-oophorectomy. نشيل بس جهة واحدة uterus عفوا جهة واحدة ovary and a tube with omentectomy with peritoneal biopsy and endometrial cortage is needed to exclude asynchronous endometrial cancer. فبيجي حالة سويت sparing to the uterus and the other side ovary and tube, so-called fertility sparing surgery. Fertility sparing surgery also performed in borderline epithelial ovarian tumor if the fertility is an issue, because usually, as we said, borderline malignancy present as stage 1A tumor. So cystectomy or oophorectomy adequate in young women, while in old women we can do hysterectomy and bilateral salpingo-oophorectomy for borderline malignancy, better for old women. But in young women we can do cystectomy or oophorectomy. Second treatment for epithelial ovarian cancer is chemotherapy. If the patient unfit for surgery or unwilling to have a surgery, primary chemotherapy may be offered. هنا ممكن أنطي as a primary treatment before the surgery. Chemotherapy so can be given as a primary treatment without surgery or as adjuvant treatment following the surgery, or we can give it for relapse of the disease. After how many years there will be relapse of the disease, we can use chemotherapy for epithelial ovarian cancer. When we use chemotherapy after the surgery or as a primary treatment for stage 2 to stage 4 and possibly stage 1C. So we can use the chemotherapy from stage 1C to stage 4. Stage 1A and 1B, there will be no indication for chemotherapy. Surgery is just enough. What are the chemotherapies? Combination of carboplatin or cisplatin and paclitaxel are the chemotherapy of choice for epithelial ovarian cancer. Most regimes are given as outpatient, 3 weeks apart for 6 cycles. Not a combination of chemotherapy and then 21 days rest and for 6 cycles as soon as possible after the surgery. رأسا بس يطلع لي الهيستوباث مالت الأوفريان cancer prove this is epithelial ovarian cancer stage 2 and above, we will start for chemotherapy. After chemotherapy, follow up by CT scan for the abdomen and pelvis and epithelial tumor marker, which is most commonly CA125, to assess the response to the treatment. Continue follow-up of the patient by CA125 for 5 years Why? To detect the relapse of the disease. During the treatment, we do the follow-up for assessment of the response for the treatment. After that, we will do follow-up for 5 years to assess the relapse of the disease. What about the radiotherapy? Intraperitoneal radioisotopes. We can use intraperitoneal radioisotopes like radioactive gold or radioactive phosphorus, which recognizes an antigen found on most ovarian cancers. This is still experimental. External beam irradiation, it's query about it. No benefit of using external beam irradiation for treatment of ovarian cancer. Survival of epithelial ovarian cancer. What are the prognostic factors? Most important prognostic factor is the staging of the disease. Stage 1 is very good prognosis than stage 3 or 4. Second prognosis factor is the residual volume post-surgery. What's the volume of the tumor left behind the primary surgery inside the abdomen or pelvis? Histological type and grade of the tumor is very important. What's the type of ovarian tumor and what's its grading? Well-differentiated, medium, or poor differentiated tumor. The age at presentation also very important. Overall, 5 years survival is 90% for stage 1 and 30% for stage 3. 90% for borderline malignancy, because borderline malignancy is as stage 1 ovarian tumor. Non-epithelial ovarian tumors. Non-epithelium like malignant 6-chord stromal tumors. Granulosa cell tumor is 70% of this type of tumor. Sertoli-Leydig tumor is very rare and may produce androgen, so the sign and symptom of it is virilization and it has a good prognosis. Usually, both of them are low malignant potential with good prognosis, both of them, granulosa cell tumor and Sertoli-Leydig cell tumor, both of them are good prognosis and of low malignancy, the 6-chord tumor. Granulosa cell tumors produce steroid hormone, especially estrogen. So, according to the age presentation, cause precocious puberty in case of juvenile granulosa cell tumors, may cause abnormal menstrual bleeding if it happened in reproductive age, and causes postmenopausal bleeding if it occurred in old age women. The peak incidence is around the menopause. Usually, the granulosa cell tumor happen in the menopause. The staging is the same as for epithelial ovarian cancer, and most of them are stage 1, so-called good prognosis. Inhibin used for follow-up of the granulosa cell tumor as a tumor marker for the recurrence. The cut surface of them are yellow. Why? Because they are secreting steroid hormone. Treatment of granulosa cell tumor is unilateral oophorectomy for young women, total abdominal hysterectomy and bilateral salpingo-oophorectomy for old women. The effect of adjuvant chemotherapy is difficult to assess. Granulosa cell tumor is chemo-resistant, not sensitive to chemotherapy, so no benefit so much from the chemotherapy. Granulosa cell tumor can recur many years later, so long-term follow-up is recommended. نحتاج high follow-up by tumor marker inhibin and ultrasound for long period of time, for many years. Surgery for recurrent is the treatment of choice. Why? Because no effective chemotherapy regime for granulosa cell tumor. إذا صار عندي recurrence, the treatment is surgery also, not like the epithelial ovarian cancer. Malignant germ cell tumors occur mainly in young women, this type of tumor. This is 10% of all ovarian cancer, and 70% of them are stage 1, also good prognosis, germ cell tumor. First of all, we have dysgerminoma. Most of germ cell tumor in the ovary are malignancy, and most of them are good prognosis. We have dysgerminoma, 2 to 5% of all ovarian cancer, and 50% of germ cell cancer. Occur in young women, 20% bilateral. Most of them are stage 1, usually solid tumor. Most of germ cell tumors are solid. The mean diameter is large, about 15 centimeters. Occasionally secrete beta-HCG, so the tumor marker of dysgerminoma is beta-HCG, like choriocarcinoma. Second cancer, germ cell cancer, is yolk sac tumor, 15% of germ cell cancer. Alpha-fetoprotein is the tumor marker of yolk sac tumor. It's aggressive tumor. هو الوحيد من germ cell tumor is very aggressive a tumor. Immature teratoma is 15% of malignant germ cell tumor and 1% of all teratomas of the ovary. All are unilateral, and 1/3 of them secrete alpha-fetoprotein. Some of them secrete alpha-fetoprotein. Non-gestational choriocarcinoma. This is very, very rare tumor, present usually in young female with irregular vaginal bleeding and high beta-HCG level. دائما نشتبه بيها ويا البريجنانسي ويا الابورشن ويا الكوريوكارسينوما. هي وبنسوي لها ultrasound راح نشوف small tumor in the ovary, solid tumor. This is called non-gestational choriocarcinoma, which is very rare. The presentation of germ cell tumor, usually young women with large solid ovarian mass, may present as acute abdomen because torsion or hemorrhage. Tumor marker, MRI, and CT scan are all of them helpful. Chest X-ray also helpful to exclude pulmonary metastasis of the disease. Treatment of germ cell cancer, usually by fertility preserving surgery. Why? Because most of the patients are within reproductive age, young age women. Explorative laparotomy, remove the tumor, assess contralateral ovary and peritoneal biopsies. This is the surgery. When we do laparotomy, we do oophorectomy or cystectomy, removal of the tumor by cystectomy or salpingo-oophorectomy, unilateral. Assess the other side of the ovary must be normal, and then do peritoneal washing and aspiration and peritoneal biopsy for any metastasis. Post-operative chemotherapy depends on the stage of the disease. Why? Because stage 1 dysgerminoma and low-grade teratoma are treated by surgery alone, no need for extra chemotherapy, while the remainder required chemotherapy after surgery. Cisplatin, bleomycin, and etoposide for 3 to 4 courses and also 3 weeks apart is the treatment of choice. This regime gives long-term cure of 90% and also preserve the fertility of the female. Why? Because most of them are good prognosis malignancy. Number 4, or the last type of ovarian cancer, is secondary metastasis ovarian cancer. 8 to 10% from GI tract, breast, uterus, and tubes. This is called Krukenberg tumor. The Krukenberg tumor, the primary source, most of them, is stomach, then colon or breast. By histopath, the tumor contains characteristic cell called signet ring cells. Signet ring cells is cell filled with mucin seen by histopath under the microscope like this picture. This is like signet ring. تشبه المحبس. ليش؟ لأنه هو this cell swelled by mucin material. This is the nucleus and this is the cell swelling by mucinous material secreted from the cell. Usually the Krokenberg tumor is bilateral and solid. Ovarian tumor in pregnancy. Ovarian cyst is usually discovered incidentally at antenatal clinic or during cesarean section because no sign and symptom. Indication of conservative management. شو وقت أسوي المريضة conservative management؟ ما تحتاج, just follow up. If the cyst below 10 centimeter. If it is simple by ultrasound. If it is asymptomatic, no acute abdomen, no severe abdominal pain. So follow up just by ultrasound only. If the cyst persists 6 weeks after delivery, surgery may undertaken then. راح نسوي لها هم after delivery for follow up by ultrasound. If persists for more than 6 weeks, the surgery may be indicated according to the type of the cyst and the size of the cyst. What about the indications of surgery? Which women need surgery during pregnancy for ovarian cyst or ovarian tumor? If the patient presents with acute abdomen because of torsion or hemorrhage, so the surgery will be done regardless of the stage of pregnancy. The operation should be covered by tocolytic drugs. Why? Because the surgery will cause contraction. The complication of the surgery is preterm labor or abortion because of uterine contraction. So the surgery better to be covered with tocolytic drugs, especially progesterone treatment for relaxation of the uterus. So when there is acute abdomen, we will do straightforward surgery regardless the age of the fetus. The other indication of surgery is the complex cyst and increasing in size. يعني من أشوف complex cyst and increasing in size during the follow-up ultrasound scan, this another indication to do surgery even during the pregnancy. If asymptomatic patient, it's prudent to wait until after 14 weeks gestation. إذا البريجننت كانت asymptomatic, هي تحتاج surgery لكن asymptomatic, يفضل إنه أأجلها after first trimester. Why? To avoid the removing of corpus luteum cyst upon which the pregnancy is still dependent. لأنه بالفirst trimester دائما السيست هو يكون corpus luteum cyst. فإذا شلتها راح تصير abortion عند الفيميل. ليش؟ لأن هذا الcorpus luteum the fetus depend on it and its development. So better to do in the second trimester. The surgery for ovarian tumor, the best time for it is second trimester. Why? Because in the first trimester, it may be corpus luteum cyst and removal will cause abortion. In the third trimester, the uterus will be very large and the access to the ovary is very difficult. So we will need a large abdominal incision and high manipulation of the uterus and the abdominal organs to access the ovarian cyst. Ovarian cancer with the pregnancy is uncommon, less than 3% of ovarian cysts. Suggestive cysts are one that is growing during follow-up, should be removed surgically. CA125 not useful in pregnancy. Why? Because it is physiologically elevated in the pregnancy. Ovarian cancer managed by cesarean hysterectomy, bilateral salpingo-oophorectomy and omentectomy. إذا إحنا proved this is ovarian cancer, فش راح أسوي لها البيشنت؟ بالثيرد trimester أسوي لها cesarean hysterectomy, bilateral salpingo-oophorectomy and removal of the omentum. Thank you so much for your listening.